All right. Welcome back to Ground Rounds for the Department of Medicine at Washington University School of Medicine. I'm John Hickman, one of the chief residents, and it's my pleasure, as always, to welcome you here. On behalf of our chair, Dr. Frazier, Dr. Spencer, Costco, and myself, we are so glad to have you here with us today for a very special talk. For the Grand Rounds series, we've started a new, what we call kind of a bucket system. It's a chance for us to make sure we have a diversity of topics and that we really get a good breadth and scope of interesting things for us. And in that vein, we've started one called Specialty Year in Review. We'll have our first talk in that today. It's a chance for us to hear from a specialist in an area of medicine on new developments, guidelines, important trials, and the like over the recent past. Thank you to everyone that submitted feedback for us. We've already invited some new speakers based on that content. There will be another optional QR code at the end of today's presentations. We'd absolutely love to hear your thoughts on past Grand Rounds, ideas for new Grand Rounds, new speakers, and the like. As always, please send questions through that Q&A function. I will help moderate those with our speaker when we have a moment. And please help me welcome Dr. Osama Altayar, who has generously agreed to join us today. He took on a very difficult topic, and we are so glad he is here. He's a recent graduate of our GI Fellowship Program. He has stayed on as faculty as an assistant professor in the Division of Gastroenterology. He attends frequently on the inpatient GI service and is known to many of us, me personally, as one of our top clinician educators. He is actively involved in numerous areas of research and is emerging as a leader in GI, particularly in the world of celiac disease. Dr. Altayar, thank you so much for being here.
Thank you, John. Thank you all. Thank you for having me today. Can you hear me well? Yeah? Good. All right. So just starting with disclosures, I have no financial interest to disclose at all. So when I was thinking about what I'm going to do today, the task was, what is new in GI in 2021? And this is just from the task that I was assigned. That could include new guidelines, landmark papers, research, or clinical pearls. And I thought, well, the first thing that came to my mind, this should not be about COVID here. We're talking about updates in the GI. We're having some COVID fatigue. We're going to hear about it if it's COVID related. Then I thought, well, what is new in GI and is not COVID related? And once you start thinking about GI alone, you start thinking about the first thing that comes in mind usually is endoscopy. But I thought, well, if I'm going to talk about endoscopy and innovation in endoscopy, there will be a lot of things. And I thought we're really trying to focus here on a more broad audience. So I'm not going to focus on endoscopy and innovation in endoscopy. Then I'm a luminal gastroenterologist, so I thought maybe I should avoid liver, pancreas, and biliary diseases. And then when I thought about luminal GI, there's this special part in luminal GI that is really broad, and it's a field on its own, inflammatory bowel diseases. So I thought, well, again, we're not going to discuss inflammatory bowel disease today. And I thought in GI, in the simple child mind that I have, that esophagus, stomach, small bowel, and colon. And I'm just going to focus on something that covers each one of these organs in terms of topics. So the objectives for today, we're going to talk about how to deal with concerns regarding the chronic PPI use based on recent guidelines and when to stop PPI and refer for evaluation. We're going to talk about, then we're going to shift gears and talk about emergent therapies for celiac disease. And then we're going to shift back and talk about colon cancer screening and the new guidelines that came out in 2021. We're going to go in depth about some of these things just for us when we discuss with patients about what to do and why we're recommending certain things. So the first part about the use of PPI and GERD is going to be based mostly on the newly released American College of Gastroenterology guideline for the diagnosis and management of gastroesophageal reflux disease. It was just released about a month ago. Still in press. Looking at this guideline, just big picture, it was a great framework-based. It gave great framework-based recommendations. Now, in addition to the recommendations, they had some key concepts, what they call key concepts. They're more like best practice statements. And if you look at this guideline, it's really a large guideline. There are about 30 recommendations in addition to about 10 to 15 best practice statements. And what got my attention the most is the long-term PPI issues. They had this subtitle about long-term PPI issues. And they had 7 best practice statements or key concepts, what they call key concepts. When we think about long-term PPI issues, this has become something that involves every organ. You know, just Google PPIs, adverse events, and you're going to see different things. And every year we hear something new. This guideline focused on some of them only, and those are the ones that I'm going to discuss today in details. However, what we talk about when we talk about those adverse events, almost the same ideas apply. You will see at the end. So before this guideline, we had the AGA best practice advices that came out from the Clinical Practice Update Committee from the American Gastroenterology Association. The first topic that I'm going to discuss is micronutrients, bone mineral density, and kidneys. And the AGA best practice update advice was in 2017 was that long-term PPI users should not routinely raise their intake of calcium, vitamin B, or magnesium beyond the RDA, and that long-term PPI users should not routinely screen or monitor bone mineral density, serum creatinine, magnesium, or vitamin B12. That's from 2017. Now, this guideline tried to divide those into small topics, and I'm going to share with you the evidence behind those key concepts or what we know about this. And at the end, I'm going to show you why the ACG came with these recommendations or key concepts or best practice statements. The ACG said that for patients with GERD on PPIs who have no other risk factors for bone disease, we do not recommend that they raise their intake of calcium or vitamin D, or that they have routine monitoring of bone mineral density. And if you look at the data behind vitamin D, calcium, and bone mineral density, actually, when you look at the data on PPIs, you'll see a lot of observational studies. So what I'm going to share with you is a lot of forest plots, just to orient ourselves with forest plots. When we talk about forest plots, we have the studies on the left, we have the effects on the right, the forest, representing the studies here, and then we have the diamond at the bottom representing the full estimate. And then usually we have a measure of heterogeneity between the studies. Usually it's the I-squared. If you look at this forest plot, there was about 10 studies. This is from 2011, and the full estimate that there was an increased risk of hip fractures with an odds ratio of about 1.2, with a confidence interval ranging between 1.1 and 1.4. There was heterogeneity with an I-squared of 65%. But if you look at the studies, the majority of them showed increased risk. Just go about 10 years later, you will see that there is about 20 studies published compared to this. Now, the proposed mechanism for this is that the PPIs the reduction in the gastric acid causes calcium malabsorption, which may lead to decreased bone mineral density, that the PPIs may affect the osteoclast, and that there's concerns that the PPIs cause, the hypergastrinemia caused by PPIs could cause parathyroid hyperplasia. And just go again 10 years later, you'll see that there are 20 more studies, 10 more studies published, all observational studies, again showing the same thing. There's increased risk. The magnitude of effect is low still. The relative risk is about 1.2, ranging between 1.1 and 1.3. There's heterogeneity again. However, as I said earlier, the American College of Gastroenterology recommended against. Then vitamin B12, it's kind of the same recommendations. Patients who don't have risk factors for vitamin B12 deficiency, they did not recommend that they raise their intake of vitamin B12 or that they have routine monitoring of serum B12 levels. And the mechanism that is proposed here is that the reduction in gastric acid results in malabsorption of the protein-bound cobalamin, and gastric atrophy results in decreased intrinsic factor production. Looking at the studies, again, we have multiple observational studies showing increased risk of vitamin B12 deficiency. However, the AGA recommended against checking these routinely. Now, looking at the magnitude of effect, which I'm going to discuss every time, we see that the hazard ratio is about 1.8 here. Finally, renal diseases. The ACG, again, recommended that for patients who don't have other risk factors for kidney disease, that we should not routinely monitor the serum creatinine. Now, they gave a hedge statement after that, another key concept, and they said that PPIs can be used to treat GERD in patients with renal insufficiency with close monitoring of renal function or consultation with a nephrologist. Now, we would hope that patients who have renal insufficiency are having their renal functions monitored routinely. So that's what happens usually in practice. Now looking at the effects, this is the first forest plot is it's on comparing PPIs to no PPIs, and you can see here that again the pooled effect with a relative risk is about 1.3, ranging between 1.2 and 1.5. So again, we have a small magnitude effect. Comparing PPIs to H2 blockers for chronic kidney disease, end-stage renal disease, also there's increased risk ratio about 1.3 here. Additionally, acute kidney injury, there's also data on it showing that there's increased risk. We're looking at a relative risk of 1.6. However, as I just mentioned earlier, the ACG still recommends against routine checking, against routine monitoring. Now, the reason is that we have additional data. We have different data. All this data that we're looking at is mostly based on observational studies. When we think in the hierarchy of evidence, when we talk about observational studies, we're talking about low certainty evidence overall. There was a randomized controlled trial that was that came out 2 years ago. It was a 3x2 partial factorial double-blinded trial. They recruited patients who had stable cardiovascular disease and peripheral arterial disease. The first part of randomization was randomizing the patients to rivaroxaban and aspirin, rivaroxaban and aspirin. And then the part that we're interested in the most is this part where patients who were not on PPIs were randomized to receive PPI or no PPI. The number of patients that were involved in each arm of those patients who had no PPIs was about 9,000 each arm. The median follow-up time was about 3 years. And the first outcome they looked at was myocardial infarction and stroke. And just looking at these curves, you can see that there's not much difference between patients who receive PPIs or placebo. And then the other thing is those other concerns that we have about PPIs. So they looked at gastric atrophy, C. diff infection, enteric infections, chronic kidney disease, dementia, pneumonia, fractures, COPD, diabetes. And you can look at the odds ratio. There's really no difference between PPIs and placebo, with one exception, which was for the enteric infections. So that's why the ACG and the AGA frequently recommend that we should not monitor. There is concern, yes, but the randomized control trial that we have showed that there's no concern really. We're likely dealing with low certainty evidence here, showing that there is a problem, and maybe this is a moderate to low certainty evidence here. Just likely this randomized trial had some limitations, so we're dealing with moderate to low certainty evidence showing that there's actually no concern. Now, the other issue that comes out frequently is clopidogrel. And the concern here is that PPIs are metabolized by the same enzyme needed to activate clopidogrel. So concomitant use of these drugs may decrease the antiplatelet effect of clopidogrel. In 2010, there was a joint statement between cardiac and GI societies, mainly the ACG. In that statement, they said that clinical decisions, as we do every day in clinic, should balance overall risks and harms. They talked about there were some pharmacokinetic and pharmacodynamic studies using platelet assays showing that there's decreased activity of clopidogrel when given with PPIs. However, they focused on the important thing here, which is the clinical meaningfulness of this finding, and that it's not established that those changes in those surrogate markers or surrogate endpoints translate into clinically meaningful differences. Then, of course, we have a bunch of observational studies, again, looking at this outcome. The first one here is looking at association of PPI with major adverse cardiovascular events, and those you will see, other meta-analyses. Now I'm showing a few of them, but there's really each topic has maybe 5 or 6 or 7. I'm showing conflicting findings depending on how strict the inclusion criteria they had. Now this one here showed the increased risk of major adverse cardiovascular events. If you look at the magnitude of effect, again, we're looking at 1.1 or 1.2 with a range of 95 confidence interval of 1.1 to 1.3. There is some heterogeneity also present. Then another systematic review that came out this year actually tried to divide those studies into randomized controlled trials and cohort studies. And when you do this, you see in both no difference actually in the pooled effect. Now this systematic review had a more strict inclusion criteria, so some of the studies that were included in the trial were excluded. Now, another one that came out 2 years ago looked at the effect of the concomitant use of PPI and clopidogrel on all-cause mortality. And what's interesting here, when you look at the cohort or case control studies, you see there is an increased risk. And once you look at the studies that have propensity-matched observational studies or post hoc analyses of randomized controlled trials, you see no difference. So again, there's maybe an increased risk. The magnitude of effect, again, is small. It's about 1.2 with a range of 1.1 to 1.4. If you look at cardiovascular mortality specifically, again, that same meta-analysis did the same thing, compared cohort or case control studies showing increased risk, while if you're looking at higher quality studies or higher quality observational studies, you see no difference. Now, the ACG guideline, this was the recommendation for patients with GERD on clopidogrel who require maintenance therapy. So those are patients who have LA grade C or D esophagitis. Those are patients with Barrett's esophagus. Those are patients who have symptoms that are not adequately controlled alternative medical therapy. And they have this really strong statement saying that the highest quality data available suggests that established benefits of PPI treatment outweigh their proposed but highly questionable cardiovascular risks. Now, why are we saying this again? There's some data, there's some concerns that are present. And this is, again, there's a randomized controlled trial that was done, that was published in 2010, in which patients who required treatment with clopidogrel for at least 12 months were randomized to receiving clopidogrel with omeprazole or clopidogrel with placebo. There were about 1,800 patients in each arm. This trial was terminated prematurely because the sponsor lost financing, essentially. It wasn't terminated because of differences in effect. The median follow-up was about 106 days. The max was about almost a year. If you look at the outcomes, there was decreased risk of GI events. There was no difference in composite cardiovascular events. There was no difference in myocardial infarction. There was no difference in revascularization. Now, this termination early is problematic somewhat. So that's why, again, if you look at the data, we have low certainty evidence showing that there may be a problem. Again, maybe here we're dealing with low to moderate certainty evidence showing that there's really no problem. And this is where the ACG recommendation is coming from, that, you know, there's high quality data supporting that it's okay to use in the right patients, and that there's low quality data showing, or low certainty of evidence data showing increased risk or maybe no differences we showed earlier. Now, when we look at all these things, when we look at all these studies, now we just discussed a few of them, we always have to think about association and causality because we're looking at observational studies. And Dr. Vasey and colleagues looked at, used the Hill criteria for assessing causality. And they looked at the different things. You can see on top, you have the interaction with clopidogrel, fractures, community-acquired pneumonia, SBP, bacterial infections, and different ones. And they looked at did any of these associations meet the causality, have enough support for causality. And once you look at this, the majority of these things don't. Once you look at the data, once you look at the magnitude of effect. The other thing that I mentioned frequently during my talk is I was talking about the relative risk being low, 1.2, 1.1. And this is really important whatever we do. Because when we talk about statistical and clinical significance, this matters a lot. When we're talking about relative effects, when I tell somebody they have 3 times risk of having problems, but the baseline risk is 3 in 100,000, that's 9 in 100,000 people. That's different than, say, when the event is high in the first place. So the same paper by Dr. Vasey and his colleagues looked at the absolute excess risk from PPIs using that low certainty of evidence data. So we're dealing with low certainty of evidence data here and looking how much absolute risk we're getting. And if you look at this, we're usually looking at very small absolute excess risk. So sometimes 0.1, 0.2%, 0.2%, there's even lower than these numbers. So this is really why when we talk to patients, when we discuss the concerns about PPIs, we should keep these things in mind. Now the ACG, let's go back to their guidelines, to some of the statements that they had there that would help the clinicians navigate through these issues. So when to stop PPIs, when to think about stopping PPIs. I just picked a few of the recommendations that I thought were relevant to this. So for diagnosis, they recommended attempting to discontinue PPIs in patients whose classic GERD symptoms. So if you have somebody with classic GERD symptoms, you give them PPIs, they recommended that you attempt to stop it in 8 weeks, after 8 weeks of empirical therapy. that's the first attempt. So it's trying to protect the patients from the potential low certainty evidence harms. They also recommended that in those patients who don't respond adequately, or patients who have their symptoms returning when you stop the PPI, to undergo diagnostic evaluation about 2 to 4 weeks after discontinuing PPIs. And this is really mostly to see if there's any evidence or conclusive evidence of GERD, like esophagitis, erosive esophagitis, because then you will start them and they may require maintenance therapy with PPI. In their medical therapy section, they also had few checkpoints. So in patients who don't have erosive esophagitis, so LA grade C, D, or Barrett's esophagus, and those who have symptoms resolved with PPI therapy, that we also should attempt to discontinue the PPI or switch to on-demand therapy. So if somebody doesn't have evidence of erosive esophagitis and their symptoms got controlled with PPI therapy, we should try to discontinue or switch them just to on-demand therapy. Now then they had another statement which is about which patients need maintenance therapy. Those are patients with LA grade C or D. So those patients would benefit from maintenance therapy with PPI or anti-reflux surgery. But even for those patients, they had another safety guard here. So for patients who require maintenance therapy, the PPI should be administered at the lowest effective dose that keeps the symptoms controlled, but also maintain healing of reflux esophagitis. Again, I'm just going to this is just searching Google randomly. You'll see all these different things. You'll see a link to regular heartbeat. I picked some of them that had no commercial associations. All right, so we talked about PPIs, the concerns about PPI. Let's shift gears to small bowel. So PPIs covers both esophagus and stomach here. Let's move to the next organ, small bowel. When we talk about small bowel, we're talking about here celiac disease. What we're seeing here is a blunted villi, essentially. So there are a lot of emerging therapies for celiac disease, nothing approved yet, but this is really an exciting field now. I'm just going to start with a small background here. So celiac disease affects about 1% of the population. Although the term celiac indicates that it's likely an abdominal problem, it's really a multi-systemic disease. So there are dermatologic manifestations, there are bone health manifestations, there are joint manifestations. Different organs could be involved when patients have celiac disease. And the diagnosis is usually based on the biopsies showing villus blunting, in addition to the serologic test. And there has been a lot, it's really an exciting field, and a lot of historical milestones have happened over the past 100 years. Starting with when we discovered that gluten-free diet was the treatment in 1940s, then discovering that there are certain HLA-B2 associations or that are required to have for patients to have celiac disease, then the discovery of the antibodies, and finally the discovery of additional antibodies that we're using on a daily basis, CpGs. Unfortunately, despite all this, the current treatment is only gluten-free diet. And the reason we need additional treatments is this. When you look at how often patients who are supposed to be in gluten-free diet are inadherent, you can see that in children on top, the blue, the range is about 8 to 43%. When we look at teenagers, we're looking at about the same numbers. Even in adults, the range is about 9 to up to 69% of adults who are supposed to be in gluten-free diet are not on gluten-free diet. And that's really problematic. And the reason it's happening is this. Celiac disease or being on gluten-free diet or a restrictive diet is extremely difficult. For children going to school, going out with their friends, living with their families even, they need specific meals. They can't eat when their friends eat. For adults, the same. If you're socializing, if you're traveling, you have to plan everything, even going to work. So there is a lot of psychological impact, psychosocial impact for this, and it adds a lot of burden on patients. So what are the other options? Luckily, we have learned a lot about the disease over the past 20, 30 years. We know a lot of the mechanisms on it. So there are different phases where we could intervene on this. The first is modifying the gluten itself. So modifying the gluten-containing cereals to mask the antigenic capacity that it has. So that's one option that we could have. Another option is detoxifying the gluten while it's in the lumen. So there are some enzymes that are working on this to essentially prevent the gluten from causing, again, inflammation. 3, blocking the gluten or the gluten polypeptides from accessing the lamina propria. So there's some zonulin between the epithelial cells blocking that. There's a phase 3 trial on this currently happening. Three, there's modulating or modifying the gluten by using bacterial therapy or microbial therapy in the lumen. Another way, which we're going to talk about, is inhibiting the tissue transglutaminase enzyme, which essentially deamidates the gliadin or the gluten polypeptides, which are required. The deamidation is required for the antigen-presenting cells, so you can inhibit that enzyme, and hopefully you can inhibit the inflammatory response that is happening. And then you can also try to induce tolerance to gluten. We're going to see this. And finally, maybe inhibit the pro-inflammatory cascade the same way we do with inflammatory bowel diseases by inhibiting the pro-inflammatory cascade. And there are a lot of trials. There are trials, there are things that are preclinical, there's studies, phase 1 studies, phase 2, and there's even one phase 3 trial that is going now. And I'm going to discuss some of the trials that were published in 2021 because we're talking about 2021. Okay, so the first trial is the trial that was published in the New England Journal of Medicine on the transglutaminase 2 inhibitor. In this trial, so you will see that in celiac trials there are two different types of trials. The first one is this type, where we have adults with celiac disease controlled in a gluten-free diet for 12 months. And then what we do is we tell those patients to eat gluten and give them the medication and see if an inflammatory response will happen or not. This essentially, hopefully, will help patients who are, maybe they want to use it on as-needed basis when they're traveling or going out, or just use it on a daily basis. And in this trial, they randomized patients to different doses of the medication, ZEB 1227, and placebo. And the outcomes that they had were the villus height-cryptic ratio. This is essentially presenting the villus blunting. So if the ratio is high, then you have no blunting. As the ratio shrinks, then you're likely dealing with villus blunting. And the other thing was celiac symptoms at 6 weeks. And in this study, you can see these are the absolute numbers, that patients who received the placebo had way more reduction in the ratio, in the villus height-cryptic ratio, so they developing villus blunting. Symptom-wise, also those patients who were receiving placebo also had an increase in their symptoms. And this is just comparison between compared to placebo, how much effect was seen. So this is really exciting. This is a phase 2 trial. They had also other outcomes. They had quality of life outcomes. They had tissue and serologies. The limitation here is that we're looking at a very small dose of gluten, 3 grams, which is not to induce inflammation, but the regular diet usually contains about 12 grams of gluten. And this was also a short period trial. So we have 6 weeks only. We don't know what will happen about, a year later. If somebody's doing this on a daily basis, what would happen. But this is exciting. The other trial was randomizing patients to budesonide. Now, this study is a different design here. This is inducing remission sooner. So you have patients who have celiac disease, just diagnosed, you start them on gluten-free diet, either give them budesonide or placebo and see if you can induce remission sooner. And what they did is they did biopsies at 8 weeks and biopsies again at 52 weeks. March is the classification that is used for the biopsies. March 0 is the normal. March 3 is when you have full-blown celiac disease. And when you look at, unfortunately, the study was not as rewarding. There was, although there were some differences, they were not meaningful differences, whether it's in biopsies. Similarly, and symptoms-wise, there was not much meaningful difference. So this was not a successful trial as much as the other one was. Next, the third trial that I'm going to discuss is the use of PLGA antigen nanoparticles encapsulated Gliadin. So this here is targeting modulating the tolerance to gluten. So inducing preventing the immune system from starting an immune response to gluten specifically. And this is similar to the first trial. So they had patients that were on that had celiac, controlled a gluten-free diet for 6 months, randomized them to medication or placebo. They gave them 12 to 6 grams, so this is a higher dose of gluten. And they looked at the change in the gliadin-specific interferon spot-formulating units. So these are the cells that are forming essentially as an immune response. And the other outcome that they looked, and this is at 2 weeks, the other outcome they looked at was the development of villus blunting. Now, what the study showed was that there was a decrease in the SFUs in those patients, so that they were able to blunt the immune response or the activation of the immune system in celiac disease patients who receive the drug. Unfortunately, though, this did not, although there was less change in the one thing, this did not meet statistical significance here. There was no data on symptoms reported. This was also a very short trial, so it was only 4 weeks. And the sample size small. So maybe it might be promising, just at least seeing that we can blunt the immune response. So these are some of the trials that were published in 2021. There were some that were published even the years before, but we're not going to discuss them. There are additional trials that go in. There's phase 1, phase 2, and phase 3. We're going to be part of the phase 3 trial pretty soon. So for patients that are more interested in trials, we can involve them, hopefully. And that's our talk about celiac disease, the part about the updated celiac disease here. Next, 45 is the new 50. You've likely heard this now. I usually, again, we're shifting gears here again. I like to look at Google Trends. Google Trends, seeing how things are happening, what's changing over time, what are people looking up on Google, essentially. And this is over the past 5 years. You can see that there are 3 peaks. People looking up colorectal cancer screening. The first one was in May, June 2018. And that is when the Colorectal Cancer Alliance published their Young Onset Colorectal Cancer Survey report in 2018. In that report, they showed that the majority of patients that were diagnosed before the age of 50 were in the age group of 40 to 50. That's also the year when the American Cancer Society was the only society who recommended that colorectal cancer screening should start at age 45. Now, the second peak, which is the highest peak in 20 years, I think there's only one peak that competes with it, is when Chad Boseman lost his battle with colorectal cancer, the famous Black Panther actor. And then the third peak was relatively recent in 2021, and that's when the U.S. Preventive Service Task Force published their new recommendations for starting screening at age 45. So 45 is the new 50. Where did this start? This started, as I said, by the American Cancer Society in 2018. There was not a lot of pickup for this. I remember it was DDW even. There was a lot of discussion about it, but not much happened at the time. Then the U.S. Preventive Service Task Force in October 2020, published their draft recommendations. And then just the floodgate opened up. So the NCCN recommended screening to start at age 45 in early 2021. The American College of Gastroenterology came up with their solo guideline in March 2021, also recommending start screening at age 45. The U.S. Preventive Service came out, task force guideline came out in June 2020. And finally, the Multi-Society Task Force, which is the combination of the GI societies, American Gastroenterological Association, American College of Gastroenterology, and American Society of Gastrointestinal Endoscopy, they come up, that's the Multi-Society Task Force, came up with the same recommendation. So now there is endorsement by everybody for this compared to 2018. I'm just going to look at the recommendations, briefly here. So you can see that the U.S. Preventive Service Task Force had different grading for age 50 to 75 and age 40 to 49. So for both, it said the same statement: recommend screening for cancer in all adults aged 50 to 75, and the other one is in adults aged 45 to 49. And these gradings, this is what they mean. So the grade A means that there is a high certainty that the net benefit is substantial, while grade B, the U.S. Renal Service Task Force uses it when there is a high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. Now, the Multi-Society Task Force uses a grade framework, and their statement for 45 to 49 was to suggest and that there is weak recommendation and low quality evidence. And weak recommendation usually means that the majority of people in this situation, so only the majority would want the recommended course of action, but many doesn't or wouldn't. While for age 50, they give a strong recommendation and they use the recommend statement. And this usually reflects that most people, compared to majority in this situation, would want the recommended action, only a small proportion would. So where did this come from? Why suddenly? And actually, how did the American Cancer Society come with this in 2018 and nobody else picked it up? This is their justification in 2018. The recommendation to begin screening at age 45 years is based on disease burden, results from microsimulation modeling, and the reasonable expectation that screening will perform similarly in adults aged 45 to 49 years as in persons for whom screening is currently recommended. And this is some of the data that they shared. So first, they looked at patients who had colorectal cancer that were younger than age 50 and had colorectal cancer, and they looked at the incidence rate per 100,000, and they compared Black Americans to White Americans. And as we all knew before, previously it was recommended for Black Americans to have the colorectal cancer screening start at age 45. And when they looked at the incidence, it seems like it's starting to pick up in younger white individuals. So this is one part. The other thing is looking at other populations like Alaska Natives, there's even a higher risk than anybody else. So that's the first one. So the incidence is reaching the population that we're already doing this for. Two, they looked at patients, compared men and women overall who were older than 50. And then you can see here that the incidence of colorectal cancer is decreasing over time. Now, when you start looking at younger individuals, aged 20 to 49, you can see how the incidence is increasing in that population. The other thing that is interesting is this here. So this is just looking at patients at the time of diagnosis, how old they were. And you can see how, if the incidence is decreasing for older ages, it's increasing for younger ages. Now, when you look at the time of birth, when you look at the birth cohort, so what you're looking at here is that when you look at 1950, so this is people who are born in 1950, when they are 20, how much their risk is, how much their risk when they're 25 to 29, when they're 30 to 32. And you can see that as the birth cohort advances, the risk is increasing in younger individuals, and it's decreasing in older individuals. So this is telling us, or the suspicion here is that we're going to start seeing even earlier cancers just by birth. It's a birth cohort effect. It's not it's not that we're detecting cancer earlier. There's really a birth cohort effect. That's what the concern is about. Some speculations about this is the change in lifestyle, the Western lifestyle, the increase of obesity. There's really it's mainly speculations, no clear data why this is happening. The last thing that they did is that they did some microsimulation models. And these microsimulation models are similar to the microsimulation models that the US Preventive Service Task Force do usually. These microsimulation, the ACS were not in agreement with the models that were done in 2016 by the US Preventive Service Task Force, and they thought that these models did not use the most recent data that was showing an increase in younger individuals. So they actually redid the same models. They reached the same groups that were doing these models for the US Preventive Service Task Force to do the same models, but using the different data. And their data, what you're looking at here in blue is if you start screening at age 45, and the gray or beige color is if you start at age 50. And what you're looking at here is life years gained if you start screening at age 45 or gray. Now, the different bars you have, the first one is colonoscopy, second one is colonoscopy. So using different screening tests, you can see here that we're gaining life years if you start age 45, regardless of the method that you use for screening. So this is the data that the American Cancer Society that used in their justification for that recommendation in 2018. Now, the US Preventive Service Task Force kind of used the same data. I'm just going to show you a few differences. And I'm just going to use the statements that they used there to say why they made this recommendation. So they said that they found adequate evidence that screening for colorectal cancer with any of the modalities in adults aged 45 to 49 provide a moderate benefit in terms of reducing colorectal cancer mortality and increasing life years gained. That's one. Two, they said that although the original studies that we have on reducing colorectal cancer mortality, they were mostly done in individuals that were older than 50. Some of the older studies on fecal occult blood testing, which we rarely do now, or we don't do even at all, included patients that were younger than 50, and those studies showed benefit. When they also looked at the harms, and I'm going to show you the data, the harms of screening are small overall, especially in younger individuals. We think that the harms are even less than older individuals. Finally, their conclusion statement, there's moderate certainty that there's moderate net benefit of starting screening for colorectal cancer age 45 to 49, and this is why they categorize it as B. Now, these are the simulation models that they did. So they did additional simulation models to the ones that the American Cancer Society did. And what you're looking at here on the left is you have the different screening modalities that we have. The first column is at age 50, the mean life years gained. The second column is mean life years gained at 45, and the third column is the difference between them. And you can see the dark green is the additional benefit that we're getting. And you can see if you start screening at age 45, there is a gain of about 24 to 27 life years gained for 1,000 individuals screened. That's one. They also looked at the reduction in cancer death, in colorectal cancer death specifically. So that was initially, life years gained, so overall survival. This is cancer-related death specifically. They also showed a reduction. Now, it's not as substantial as that number that we saw earlier. There's a reduction by one if you start screening at age 45. Then they looked at the harms, and what we're looking at here is the number of cardiovascular and GI complications if you start screening at age 50 or age 45, and there's really not much difference between the two. Then they looked at the number of procedures that we're going to perform additionally if we start screening at age 45 or age 50, and you can see here that with different modalities, we'll definitely do an additional test, mostly if we start with colonoscopy. And however, the main thought is that we have the capacity to accommodate those tests. And actually, I'm going to show you some data why we may even have more capacity based on the change in how we do surveillance. Finally, the multi-society task force. These are some of their statements. They use the same data or some additional data, but these are some of the statements here. So the increasing colorectal cancer incidence and mortality, such that incidence rate for 45 to 49 years old now matches incidence in populations that are already eligible for average screening. So the incidence in 45 to 49-year-olds is similar to the incidence observed in 50-year-olds in 1992 when colorectal cancer screening was first recommended. So we're reaching the same level. And incidence in all 45 to 49-year-olds is currently similar. As I showed you earlier, the incidence is picking up in some other populations to the incidence in Black Americans aged 45 to 49, for whom the task force already recommended average screening in 2017. Emerging data shows that the rate of advanced colorectal neoplasia, so now we're talking about polyps, advanced polyps here, in average individual in that age group is similar to the older age group. So this is more data here saying that, well, maybe we should do screening. They looked at the same modeling studies that were done by the multi-society, by the U.S. Preventive Service Task Force, and they thought there was an acceptable cost effectiveness and that we, as GI societies, we have enough capacity to do this. This is just some of the nice figures that they had. This is based on the CR9, so this is the most recent data. The incidence rates, you can see how they're increasing in people who are age 65 and higher. You can see how it's also decreasing in patients who are 50 to 65. But when you look at individuals who are younger than 50, you can see the increase in the incidence rate. They also had this nice table comparing early age onset colorectal cancer to late age onset colorectal cancer in some clinical and pathologic features. So the majority of early cancers that we have currently present with symptoms in younger individuals. When you look at early cancer, it's rarely detected with incidental screening compared to the late onset. When you look at the duration of symptoms, most of these patients had longer duration of symptoms. There was longer time to diagnosis compared to patients who are had late onset or late age onset colorectal cancer. When we look at family history, the majority of the earlier, or not the majority, the early cancers were more likely to have family history. The location, the early cancers were more likely to have left-sided cancers compared than right-sided cancers. The histology, they were more likely to have poorly differentiated cancers. And finally, the stage, they were also more likely to be diagnosed at a late stage. So this is even more reason that maybe we should start screening early because we're getting those patients really late when they come out in late stages. So again, this is why everybody's recommending that 45 now is the new thing. Additional data. So I talked about the capacity. And although we're recommending doing more screening, maybe more stool test or colonoscopy, regardless of the modality, we're recommending to scale back on certain populations. This came out in 2020, so I know we're talking about 2021, but I think it's relevant. So in 2020, the multi-study task force on colorectal cancer changed the recommendations for the time of surveillance. So previously, starting from the left, now this all assumes that we have a high-quality endoscopy, the colonoscopy. We're reaching the cecum, we have a good prep, we have the colonoscopists have good adenoma detection rate. When we're resecting polyps, we're resecting them completely. Previously, and currently, if somebody has normal colonoscopy, the repeat is in 10 years. If they have less than 20 hyperplastic polyps that are small, repeat in 10 years. Now, this is where we start seeing change. Previously, individuals who had 1 to 2 adenomas that were less than 10 millimeters, the recommended surveillance interval was 5 to 10 years. Now, they still have this hedge number of 7 to 10 years, but it's at least longer. So we're doing less colonoscopies, hopefully, by doing this. When you look at a new category that they didn't have before. So previously, if a patient had a sessile sebated polyp, the recommendation was to have repeat colonoscopy in 5 years. Now it depends on the number. So if it's just 1 to 2, it's 10 years. 3 to 4, we're looking at 2 to 5 years. 5 to 10, we're looking at 3 years. The other one that changed is having 3 to 4 adenomas. So previously it was 3 to 10, it's 3 years. Now, if it's 3 to 4 adenomas that are small, we do surveillance in 3 years. In 3 to 5 years. So again, we're stretching it a little bit, allowing room for more patients. As for the other categories, so 5 to 10 adenomas, 5 to 10 sessile polyps, adenomas that are advanced, the repeat is still 3 years. It hasn't changed. Lastly, we have this new category. Previously, well, it's not new, but it used to be less than 3 years. It was ill-defined number. Now it's clear, it's 1 year. If you have more than 10 adenomas, you should have a colonoscopy more. Now, the updates were also reached the surveillance after the first surveillance colonoscopy. I did not discuss this here, but you can tell that if you're seeing different recommendations from us, this is because we have changed how we do things. We're doing it less frequently. Now, I tried to look up for celebrities' pictures having their colonoscopies. I found only 2. But always smile before your colonoscopy. It's easy. Additional updates from 2021. I could have done much more. There's a lot. Looking just at guidelines, and this is guidelines, so there are some clinical practice updates, best practice statements. The AGA had someone, intragastric balloons, coagulation cirrhosis is a really interesting one. They talk about how to manage coagulation cirrhosis. There's on Crohn's disease, COVID-19 endoscopy. The ACG had a couple new also on anorectal disorders, C. diff, upper GI bleeding, which had some controversial statements. Also, drug-induced liver injury, irritable bowel syndrome. ASG had some also, the American Society of Gastrointestinal Endoscopy, mostly on management of malignancies. ASLD had the liver society had new guidelines on ascites, on malnutrition, PBC. There are also some newer studies in luminal GI. So there's this new agent for GERD. It's still being studied. There's one randomized control trial that showed that if patients who don't have erosive reflux, they may benefit from this treatment. The time to endoscopy in upper GI bleeding, there's more data that came out showing that maybe what we're doing currently now is good. With supporting the patients, making sure that they're stable and not waiting more than 24 hours. There's data on the functional dyspepsia and gastroparesis, and data showing that when you do biopsies, you're likely looking at the same disorder when you're looking at the cells. We might be looking at the same condition at different spectrums or different presentation. It might be all functional dyspepsia, and those gastric emptying studies that we're doing may not be as helpful as we think. Maybe they are helpful in certain populations. So. There's also some new medications for gastroparesis, actually for GI motility overall, that should increase motility in the stomach, small bowel, and colon. The management of diverticulitis with outpatient antibiotics, inpatient colonoscopy prep, and most exciting for people who need to have colonoscopies, or even a trial on using tablets rather than actual fluids for preps. So there's more. This is just some of the stuff. While I was looking this up, what to do, I was planning to present all, but decided to shrink it to 2 topics. I'm happy to take questions. This is what happens when you have a 4-year-old and they take your phone and start taking pictures. Yeah.
Awesome. Thank you so much, Dr. Altayar. We really appreciate your talk. It was not an easy topic, but I think you covered it and then some. We really appreciate you being here. A reminder to anyone, go ahead and send any questions through the chat or the Q&A. I'll start off with one here briefly. What do you see in the history coming up for the near future for folks that are suffering with celiac disease? Do you think we're far away from a place where they can just ignore a gluten-free diet? Are we heading that direction, or are we pretty far from that still?
I think it's this is I was hearing a podcast that you should not say it's this is an excellent question, because all questions are excellent. The question is that what do we see in the future for celiac disease patients? Are they going to be ever able to eat gluten? I think there are multiple levels here. One is reducing the inflammation in the immediately after gluten. The other one is looking at long-term outcome. The concerns that we have with celiac disease patients exposure is the increased risk of malignancies, the increased risk of osteoporosis, and other outcomes. And the question is really here, if we're able to reduce that inflammation, are we going to be able to reduce those other outcomes? And we're not going to know soon. Now, do I anticipate that patients with individuals with celiac disease will be able to eat gluten? I think in the next 10 years it's possible, especially with all these exciting trials.
Another question. You were pointing out, obviously, the increased incidence in colorectal cancer, particularly in our younger populations. So what do you attribute the decreasing incidence in our older populations? Is it just a product of our effective screening so far? Because to my knowledge, they're on the same diet, and we have the same, increase in obesity in these folks.
It is really attributed to the screening. That's the attribution. Actually, if you look at cohort studies on the effect of screening, there's reduced. So the data that we have on colorectal cancer screening, there's randomized trials on fecal testing. For colonoscopies, there's large cohort studies that were done, and they both showed reduction in colorectal cancer mortality. So it's likely that's what we're dealing with, that we're likely, it's the effect of screening that we're doing, yes.
Another question here regarding PPIs. The odds ratio for fracture in the randomized trial was 1.3. The observational studies, it was essentially the same at 1.2, which was significant due to the larger populations. How justified are we to assume that the effect on fracture is not significant?
I think, what we have to keep in mind here is the baseline risk also, right? So we're looking not only at the numbers as absolute, as relative risk, we have to look at the baseline risk. The baseline risk is low in the first place. So when we're applying that relative risk to it, you're likely getting a small excess effect. That's one. Two, it's very important. We're not saying use it for everybody, just to clarify. I think it's important to keep in mind that we have to discuss this with patients. We have low quality evidence for both sides. So we have low quality evidence showing increase, but there's also a low quality evidence that's showing no difference. So when we talk to patients, actually, the ACG, I didn't put that statement. They have this long something that I guess they wanted people to copy and put in their notes about discussing the risks and benefits of treatment. And as you can see, there's all these safety checks that are implanted there about discontinuing PPIs, about going to stop PPIs, and everything. Again, balancing benefits and harms here is the key. But knowing that it's not the evidence is not conclusive here.
Thank you for that. Another question just came in and said, sorry if we missed this, but can you please comment on the blood-based screening tests that are becoming available and how they might impact care in the future?
I don't think there's any blood-based tests. I think there are early studies, but there's nothing currently. But the hardest thing to compete with is going to be the colonoscopy. That's number one. And the second hard thing is competing with the FIT testing, because currently we have higher quality data showing that whether you do FIT annually or you do colonoscopy, you're reducing mortality. Now we're assuming this applies to the other modalities, but these are I think that's where the struggle is going to be, is proving that this test not only increases detection or early detection, but also you have the concern about polyps. You have the concern about when we're removing polyps, are we reducing cancer also? Those are the parts that are missing still, and how frequently you're going to do this test. So maybe if it comes and it meets, you know, what the fit testing is able to achieve, it will change definitely. You know. But just keep in mind also that only a few countries do colonoscopy for screening. The majority of the countries, they either do flexible sigmoidoscopy or quick testing. We have the capacity here. Only a few countries, I think Germany, Austria, if I'm not mistaken, and another country have colonoscopy, but the rest of the world is not. And this is important when talking to patients too, that, you know, we should not force everybody to have colonoscopy. We should, you know, discuss all these things with them and tell them, hey, you have another option, at least to increase capture of screening.
I think that's it for us in the chat here. Once again, I just want to say thank you so much for joining us today. Thank you for a wonderful talk, taking on this challenge. We really appreciate it.
Well, thank you for the invitation and thank you for the challenge as well. All right.
Please, as a reminder, everyone, offer us some feedback if you can. We'd love to hear from you, and we will see you next time. Thank you so much.